in my background.
Welcome everyone. We're just sort of waiting for everyone to log in. We just give all the attendees about a couple of minutes, and then we'll make a start of the webinar. We'll just give everyone another minute to sign in, and then we'll make a slow start with some of the housekeeping matters, I think. I think we have a good number of people logged in now, so we might just slowly make a start. So again, on behalf of the Australia New Zealand Head and Neck Cancer Society, I want to welcome everyone to our webinar tonight, which is talking about tackling head and neck lymphedema, which is obviously a very important topic for all of us who are dealing with head and neck cancer. We specifically wanted to thank Hadamard for sponsoring our webinar tonight as well. So my name is Sally, and I'll be the chair tonight. I'm a plastic surgeon from Melbourne. I also had Hiroo, a radiation oncologist from ICON in Gold Coast, helping us to moderate the talk tonight. So thank you very much for that. And we wanted to acknowledge the traditional owners on the land which we gather today, and the many lands that we undertake our work. We recognize the continual connection to these lands, water, culture, and pay our respect to the elders past, present, and emerging. So just a couple of simple housekeeping. So if you have any questions, please leave your questions in the Q&A box. Eric will be kindly monitoring the questions as we go, and we'll have a Q&A session at the end of the talk for our panelists to respond to some of your questions. And, you know, I just wanted to do a brief intro to all our guest speakers who have kindly, you know, put aside an hour of their time to come tonight to share their knowledge with us about the head and neck lymphedema. So firstly, I've got Associate Professor Hiroo Suami, who will be focusing on talking about the head and neck lymphatic for us. So Dr. Suami is started his lymphatic research in 2001 and worked in the University of Melbourne. He developed a novel radiographic technique to demonstrate the lymphatic system in the cadaver model. And then he was awarded the plastic surgery education grant in 2005 based in the US. In 2009, Dr. Suami joined the Department of Plastic Surgery at MD Anderson and subsequently returned to Australia, and now I'm working for Macquarie University in 2015 and has been heavily involved in the Australian Lymphatic Education Research and Treatment Centre as an associate professor and a research lead. We also have Dr. Amanda Pigott. Amanda is an occupational therapist specializing in edema and lymphedema management. She worked at the Princess Alexandra Hospital, is a key researcher in the field of lymphedema at the University of Queensland, and delivered professional development education program for her private practice. Amanda had a particular interest in the management of head and neck and certainly delivered many very great sort of educational program to various allied health and as well as to the neurosurgeon area. And in recognition of her work, she was also awarded the Contribution to Lymphology Research Award from the AOA Association for her publication and presentation relating to lymphedema in the area, in particular in head and neck region as well. We also had Dr. Tian Gan, who is an accredited radiology trainee at Austin Health. Tian is actually currently doing a clinical research study that helped to correlate the CT Lymphatic criteria with the severity of the clinical symptoms in patients with head and neck lymphedema, and she'll be sharing some of her research finding with us tonight. We also had Dr. Ying Sheng Lin. Dr. Lin obtained his plastic surgery fellowship in 2016 in Taiwan. He underwent further microsurgical training in Changwon Memorial Hospital in Taipei and the University of Tokyo Hospital. He's currently working at the Boston Lymphatic Center as the lymphatic fellow at Boston, and he recently published his experiences in the lymphatic bypass in the head and neck lymphedema. So we certainly had a very broad range of panelists tonight who will be able to share with us their vast knowledge about this particular topic. So before I sort of hand over the screen to our panelists, just want to remind everyone that our ASM will be held in the 29th and the 31st of August. It will be in Adelaide. So I hope that everyone will show your interest and sign up and join us in Adelaide for a very educational 3 days. If you are not already a member of the society, please consider joining the society, and you can interact with a wide variety of allied health and also surgeons, nursing staff who are heavily involved in the management of patients with head and neck cancer. And finally, we hope that if anyone wants to support our research foundation, you can consider any donation towards the foundation as well. That's all the housekeeping that I wanted to do. I'm now going to stop sharing my screen and hand it over to Professor Suami. Thank you.
Hello, good evening, everyone. So just a moment to show my slide. Okay, here you go. So my name is Hiroo Suami, working at the Macquarie University, Sydney. Thank you for Sally for the nice introduction. So today I'm talking about the infrared imaging to how to diagnose in the head and neck lymphedema. So the first slide I just introduced in my background. So I'm trained as a reconstructive microsurgeon specialized in the head and neck reconstruction. And then I had a training of the oncologic surgery of the breast and the head and neck region at the Japan Cancer Center Hospital. So the left bottom slide. So then when I had a travel grant and then work at the University of Melbourne, so fortunately I developed a method to visualize in the lymphatic system in the animal and human cadaver. So due to my achievement, I was recruited by the MD Anderson Cancer Center Hospital as a research faculty starting at 2009. So I spent 7 years at the MD Anderson, and then during that time, I did quite a lot of the veterinary surgery, and then also keep on dissecting the lymphatic in the cadaver model, and also apply the infrared imaging in the clinical settings. So I guess most of people are not familiar with the lymphatic system. So the left slide showing the my cadaveric dissection using my own technique. So the blue stained the vessel are the lymphatic vessel. So these are the forearm lesion. And then, so the red color ink is injected separated into the vein. So then you can get some idea. So the lymphatic is a little bit smaller, but not too small to see it. So the branching pattern is different. So then the lymphatic vessel is quite uniform diameter, and then sometimes diverging, and then, but most likely to be quite independent. It's not making like a network. If I inject in the radium contrast media, so then the lymphatic course are recorded on the X-ray, and then removing the bone, and then we can clearly see which lymphatic vessel connected to which lymph node. So then when I worked at the University of Melbourne, we also investigated the lymphatic, superficial lymphatic system and the head and neck region. So the lymphatic vessel in the head, like distributed like this, and then also color-coded according to the lymph node. So can be distributed. So then lymphatic vessel connected the cervical lymph node and the occipital lymph node. So summarizing all information and also the archival information of the anatomy. So I proposing the concept of the lymphatics named the lymphosomes. So the definition of the lymphosome is a skin lymph territory which contain the superficial lymphatic channel connected to the group of the first tier lymph node. So this anatomical information is getting now the popular. So then providing the lay people to so how the lymphatic is running in the body. So then when I joined to the MD Anderson in the 2009, so I worked with a company and then succeeded to introducing the infrared machine to visualize the lymphatic system to the United States. So mainly I operated the infrared camera before the lymphatic surgery. So the arm lymphedema can be demonstrated like the right side of the video. So the advantage of the infrared imaging, so we can see the structure of the lymphatic in real time. So here is the first need to understand in the normal lymphatics. So the left diagram showing the lymphatic system. So the lymphatic started as a lymphatic capillary in the skin, and then slightly getting bigger, and then escape from the skin, and then connected to a superficial collecting lymphatic vessel. So the infrared camera can provide the information of the superficial lymph collecting vessel. So the right side of the image is a normal lymphatic in the forearm. So injecting the hotspot is the wrist lesion. And then we can see like a linear structure. So these are the structure of the lymphatic vessel. So this normal information could become work as a template to understanding what the changes occur in the lymphedema. So here is a breast cancer lymphedema patient. So then same, we can see the linear lymphatic channel and then suddenly stop in the mid of the forearm and then start to showing the lymphatic network. So it's this spider net-like network is initially the lymphatic vessel in the skin. So this skin lymphatic, when applied the massage, is gradually expanding. So the right side of the diagram showing what's happened in lymphedema. So after the actual node dissection or lymph node dissection, some of the lymphatic vessel can be compromised and then obstructed. And then lymphatic flow is backflow to the skin and then finding the patent lymphatic vessel nearby to making the bridge. So this short video showing what's happened the lymphatics after the lymph node dissection. So this is a case of the arm. So the lymphatic collectors is the main the track to carry the lymph fluid. But after the lymph node dissection, some of the lymphatic vessels are blocked and then backflow to the skin. And then lymph fluid extending through the skin until to find the patent lymphatic vessel nearby. So this is a way is a body is trying to maintain in the lymphatic fluid drainage. So now the main topic, how this kind of the information we can be applicable for the head and neck lymphedema. So this is my initial experience of the applied infrared image for the post head and neck cancer patient. So I presented Australian Asian Lymphedema Association conference held in Auckland in 2014. So this is a case of the MD Anderson, the post-pharyngeal cancer patient, and then pharyngectomy and the bilateral neck lymph node dissection. So then injecting the tracer between the eyebrow and the chin. So we can see the dermal backflow, which is a skin lymphatic network. Exactly the same way we can see identify the lymphedema in the upper limb. So this patient showing like a dermal backflow in the cheek region. So this is my initial experience for the applied infrared imaging for the head and neck cancer patient. So after I started working at the Macquarie University, our team is designed a very simple study, and then recruiting the healthy participant, 10 participants, and also the another group of the participant in the post-neck lymph node dissection. So then, first of all, we need to understand in normal lymphatic anatomy in the head and neck region. So the left is the anatomical atlas in the 18th century. It's very accurate. And then when we close look at and then apply the lymphosome concept, we can divide it into the 3 subgroups. So each subgroup is drained to the different the lymph node. So from the chin injection went to the submental lymph node. From the injection between the eyebrow is connected to the submandibular lymph node groups. And from the temporal injection is going to the upper cervical lymph node, which is a level 2 lymph node. So then we define the 4 injection sites. So each injection site assigned for each lymphatic territory. So this is the first case of the healthy control. It's similar to the normal arm patient. We don't see any dermal backflow. We only see like a linear lymphatic channel. So then from the injection between the eyebrow, so we can see the lymphatic vessel running along the parallel to the nasolabial fold. And then couple the lymph node going to be demonstrated in the neck. So summarizing this patient, so there is no dermal backflow, which is representing the lymphatic congestion. And then lymph node could be identified internal jugular chain and also subclavicular lymph node lesion. So summarizing the normal lymphatic pathway detected by the infrared imaging. So these are the potential lymph nodes. So we could identify the 3 drainage pathway from the temporary injection. So the pathway is demonstrated. So the first connected to the upper cervical lymph node, and then down to the supraclavicular lymph node. So the second pathway is the internal jugular pathway. So from the eyebrow, between the eyebrow injection, first connected to the submandibular lymph node, and then we can see the chain of the lymph node along the internal jugular vein. So the pathway is not been recognized before. So anterior jugular pathway from the chin injection site, we can see the one pair of the lymphatic pathway along the trachea. So these 3 pathways could be identified as normal the patient, and then work as a template to understanding what kind of the changes occur post lymph node dissection in the neck. So this is the first case showing the post-tongue cancer. So unilateral upper neck dissection on the left side. So the dermal background, which is a cloudy area, can be shown, so correlated with the lymph node dissected area. So the indocyanine tracer moving from the affected side of the left neck towards the unaffected side of the right neck. So we can see that this kind of the changes, very consistent. And then tracer is directionally moving towards the healthy side. So the right side, we can see the internal jugular pathway and the accessory pathway. So the left side of the lymphatic could be compromised, seems to be go downwards to access to the remaining lymph node, and also crossing the midline to connecting to the contralateral neck. So this is a summary of the first case. So unilateral neck dissection. So lymphatic congestion is identified in the operated side, and then moving towards the contralateral neck and also the downwards. So this is a second case. It's more extensive type of the surgery. So the patient having a pharyngeal cancer, bilateral neck dissection and pharyngectomy. So much more extensive. And also the lymphatic congestion area also extensive. So the lymphatic congestion started from the bilateral cheek. And then indocyanine green tracer is moving to horizontally towards the posterior side of the neck. So then when I apply the massage, you can see the dye is slowly moving towards the posterior neck region. So that some people consider the surgical scar can block the lymphatic flow, but scar doesn't mean anything for the lymphatics. So the tracer can easy to cross in a scar. So I just mark in the direction of the movement of the tracer. So in this patient, also the congestion area moving down and then crossing a clavicle, and then switch to the patent lymphatic vessel connected to the axial lymph node. There is a couple of reports said, so after the post the neck dissection, so the lymphatic could be the cancer recur in the axial node region. It's not a big cases number, but could be the potential the cancer recurrent passing through this newly pathway to connect it to the metastasize to the axial lymph node. So this is a summary. So more extensive the area of the lymphatic congestion, which is equivalent to the lymphedema, is showing on the bilateral neck. And then drainage lesion is going to the posterior neck side and also down to the bilateral axial lymph node. So then first I have no idea where the tracer is moving to the posterior neck. So that this lesion and the signal is going to be disappeared. And then afterwards, my friend is a diagnostic imaging providing the SPECT CT on the right side. So this is not the same patient. There's a patient having melanoma in the scalp. And then since the lymph node, the lymphocytography SPECT CT is clearly showing the deep cervical lymph node in the posterior neck lesion. So that could be the lymphatic flow is altered to drain to these deep cervical lymph node. The summary of my presentation is, so the dermal backflow sign was an indicator of the lymphatic compromise and then diagnostic criterion of the lymphedema. So the same kind of the image criterion can be applicable both in arm lymphedema and also the head and neck lymphedema. So the head and neck lymphedema is sometimes quite difficult to diagnose without the imaging, but infrared imaging clearly showing the lymphatic changes. And then changes in the lymphatic drainage correlated with the area of the neck dissection and without the laryngectomy. So mainly the bigger surgery having a more chance to having a larger lymphatic congestion area. Identify the compensatory drainage region and areas of the congestion may allow us to personalize the lymphedema management and the care. So the current forefront care of the head and neck lymphedema is a conservative management. So then if we know where the lymphatic flow is draining to, that information could be helpful for the lymphedema therapist to apply the personalized management for each individual head and neck cancer patient. So then ALERT program, ALERT Center, which belongs to the group at the Macquarie University, also providing some of the educational course for the lymphedema therapist. So if you have a chance, you can access to these kind of our educational course. Thank you very much for your attention, and then I'm happy to take any questions.
Thank you, Hiroo. I think that's a very nice slide just showing, how the superficial lymphatic drains, through the ICG, and certainly, really give us that sort of sense of where the problem is. I think this leads very nicely into Amanda's talk next. We'll get Amanda to talk about the conservative management, for head and neck lymphedema and share her experience in managing this area. Thank you, Amanda.
Thank you, Sally. I nearly lost my mute button for a moment, but I'm with you now. Thank you so much for inviting me to share some information about conservative management of head and neck lymphedema. I wanted just to start by going through a little bit of what we see when people are referred to us for head and neck lymphedema conservative management. So I guess some of the things that we look at are what has triggered the lymphedema in this person. We know when we look at the research so far, we've got some that are more likely triggers and some that are emerging, I think, as potential triggers for future. So we certainly see location of tumour, nodal disease extent, surgical disease extent, the dose and location of radiotherapy, and treatment dense protocols as most likely triggering for head and neck lymphedema. But it's really interesting to see some of the research showing us that age and body mass index might also be contributors. We see those as certainly body mass index as a trigger for peripheral limb lymphedema, and it's interesting to think about what the mechanism might be in head and neck lymphedema and how that affects our therapy as well. Our challenge, I guess, with head and neck lymphedema is looking at the symptom profile. So we have the physical side effects that we see with other peripheral lymphedemas, the swelling, tightness, heaviness, hardness. We do see more pain and discomfort in the head and neck region than we see in limbs with lymphedema. That's probably relating to the functional impact, the difficulty with swallowing, moving the head and neck, the trismus, the taste changes, and voice difficulties. But I think the psychosocial distress being higher than in the peripheral limb edemas, distress, anxiety, depression, particularly body image changes, really impact on that socialization, and the socialization is also impacted by those functional changes. So our challenge with conservative management is to really design a package that can address all of those symptoms. When we look at prevalence of lymphedema, I think it feeds into conservative management. We really see very high rates. I've picked out a couple of studies here. Look specifically at the internal and the external lymphedemas separately. We see rates from 3 to 18 months after head and neck cancer treatment being up around the 80 to 90% in some studies, and certainly increasing rapidly from baseline up until that 3-month point. When we try to break it down further into internal, external, and the combined presentation, it does vary between studies, but I really think a recognition in more recent years' research has been the impact of the internal lymphedema and the greater the representation of internal lymphedema in that combined profile that we see. Despite those really high rates, we know that head and neck lymphedema is an understudied condition. It's certainly under-recognised in the research literature. In clinic, it's underdiagnosed, and that unfortunately leads to it being undertreated. And that's really well supported in the Stockfield's database study, but certainly something we see clinically as well. So I'm hoping that greater awareness of conservative management in this group leads to greater recognition and referral onwards. So to give you a bit of an idea of what we do should someone be referred for head and neck lymphedema management, I thought I'd just start having a look at the assessments that we use. We're particularly challenged with assessment for head and neck lymphedema. The shape of our head and neck region is irregular, it's non-cylindrical. We cannot transfer the measurement techniques that we use from arms and legs into the head and neck region. If we look at where systematic reviews place us at the moment, we still do not have a gold standard assessment for head and neck lymphedema. We know that no one tool will suffice for either diagnosing or continually measuring head and neck lymphedema. We still fall back to clinical history and physical examination, but we do have a few different assessment parameters where we're starting to see some emerging research being more useful in guiding us with our conservative management. So I wanted to have a look through these different assessment parameters briefly with you tonight. Patient-reported outcomes, we know now, they're very important in all aspects of clinical care, but particularly with head and neck lymphedema, there's a wide discrepancy between the volume of somebody's head and neck lymphedema and their subjective understanding and subjective distress caused by that lymphedema. So somebody may have what we would consider to be mild lymphedema, and it may be highly impactful for them. So we rely heavily on patient-reported outcomes, and the two that are the most frequently used because of the strong psychometric properties they have is a lymphedema symptom intensity and distress survey, which has evolved into the head and neck lymphedema fibrosis symptom inventory, which is a slightly more brief version of the first tool. EORTC still features strongly, as does the Vanderbilt Head and Neck Cancer Symptom Survey. And we really try to use those to guide the intensity of clinical management because it really feeds into patient motivation for treatment as well. If we look at external lymphedema and size measurement, there's tape measurements are the most frequently used tool, and there are 5 systems that have been reported in the literature. The MD Anderson scale, which you can see in the bottom right, is the most frequently used in research literature. It measures the facial and neck structures. It's quite an involved system, and although it's really heavily used, doesn't have strong psychometric properties. The 3 above them also aren't supported well with reliability or validity data and don't have a rigorous assessment protocol. The really simplified assessment that we have developed, the Aloha tool on your bottom left, we found really valuable for measuring clinical change and determining whether our conservative management is having impact or not. It's a simple assessment system that uses tape measurements combined with a moisture meter and has been shown favourably in terms of its reliability and validity data. In terms of internal measurement, you'll probably be familiar with Patterson's radiotherapy edema rating scale. That's certainly the most extensively used. It's supported by reasonably strong inter-rater reliability and intra-rater reliability data. It measures 13 structures and 2 spaces, and they're evaluated for normal, mild, moderate, or severe edema presentations. If we look at clinicians' rating scales, with lymphedema, it's probably most have evolved from the Foldy scale, which is a traditional lymphedema scale. Most often used is the MD Anderson head and neck lymphedema grading scale, which then has gone on to break Foldy's scale into an additional layer where we have a 1A and a 1B level, just allowing a little further differentiation of presentations. And then we've gone on to have the head and neck external lymphedema and fibrosis scale, which is the more recent of our clinician rating scales, definitely more detailed, but has stronger inter-rater reliability data behind it. And lastly, we can measure tissue components. Most commonly used is a lymph scanner, which is used to measure the tissue water, where electromagnetic energy is emitted by a tool. It's absorbed by water molecules, and unabsorbed energy is refracted back into the device, which records the percentage water content of tissues. And we can use that to measure difficult structures like the head and neck and compare that to normative data that's being produced. We've done some research on that to show it to be quite positive in terms of its inter and intra-rater reliability. Its other researchers have found it to have low measurement errors. It's a very clinically useful tool that shows change quite rapidly. It's quite sensitive, so we use this heavily in conservative lymphedema management. I won't go on to talk about imaging because I think it's been covered really comprehensively, but if we look at those tools, that's probably the fundamentals of our conservative lymphedema assessment. If we have a look at the treatment of head and neck lymphedema, as I said earlier, head and neck lymphedema is certainly an under-researched area, and that's most prominently seen in our treatment effectiveness data. We don't have yet sufficient information about treatment modalities, which ones are most effective, treatment dosage or duration of head and neck lymphedema therapy. What we do deliver is a treatment package where a number of modalities are used in combination. Certainly when we look at that as packaged therapy, it's been shown to reduce the size of head and neck lymphedema, reduce symptom burden and reduce distress, but a lot more work to do there. Some of the modalities that have had a little more research show stronger evidence, such as taping that I'll go on and talk about, and pneumatic compression, owing to the fact that they're probably a little more attractive to the research dollar. There's also been some work looking at how we deliver conservative lymphedema therapy. We tend to start with a therapist-led approach and try to transition to a self-management approach. It's particularly challenging with head and neck lymphedema, and we see research showing us that greatest volume reductions are certainly found with therapist-led management, mostly owing to the lower rates of adherence with self-management. But certainly therapist-led management can't happen in isolation. When we look at the treatment modalities that we use, there are quite a number, and they need to be delivered at reasonable frequency, certainly daily. So that's where self-management is absolutely essential. To break these down for you, what do we do when a patient's referred for head and neck lymphedema conservative management? We spend a fair bit of time with education. The general public's awareness of lymphedema is quite limited, and it's even more limited when we look at head and neck lymphedema. So information about the condition itself, the strategies that we use, why we use them, how they work, all really trying to build engagement with self-management, self-efficacy as we progress so that we can lead to behaviour change. We try to identify and modify barriers to the engagement in self-management, and we really advocate for multiple therapy-led sessions to enable that process to happen. The multimodality treatment is, I think, quite burdensome on patients in terms of their time, and the greater understanding they have, the better our outcomes are. Other modalities we use, we really focus on posture. Following head and neck cancer treatment, the anterior neck structures are usually particularly tight in the short and long term. So we look at day posture in trying to improve neck alignment, and we also look at night posture. The pattern that we see with head and neck lymphedema is always that it is worse on waking and improves throughout the day as gravity takes effect. So modifying that nighttime posture can really reduce that accumulation that can happen overnight. Often patients come from that post-surgical space where they're doing their very best to elevate, but maybe leading to, in fact, more forward flexion and closed neck postures that exacerbate their lymphedema. In terms of exercise, we know that contracting skeletal muscles can assist with lymph transport, and often in this post-head and neck cancer space, neck and shoulder range of motion is quite limited. Trying to work with patients to build structured exercise programs, looking at those joints into their daily management, but also trying to look at whole body exercise. We want people to adhere to the COSA exercise guidelines for overall health, but we know it can stimulate lymphatic flow and lymphatic function as well. A key modality that we use is also manual lymphatic drainage, and Professor Suami has given you a really nice lead into how we design our treatment programs with manual lymphatic drainage. It's a particular massage technique that we're trying to improve lymphatic flow and drainage through the superficial lymphatic system. Through his work in identifying lymphatic drainage patterns, we have got some more accurate general principles as to where we should target our manual lymphatic drainage. And we've been fortunate in our centre to be able to link with the alert team, and particularly with Professor Suami, to be able to image our patients and individually design their manual lymphatic drainage pathways. So as we have the ICG dye injected, we can trial our MLD pathways and determine what's the most effective way of achieving drainage for each individual. MLD is really well tolerated. It hasn't been well researched in the head and neck region other than as a packaged tool, and it's certainly something that I think will be looked at further in future. Lymph taping is the use of specialised medical tapes, which we apply to the head and neck region. In theory, the alternating pressure and stretch that they apply to tissues results in greater lymphatic movement than would occur without tape. The strongest research we have for this is ATAR's randomised controlled trial, which did show that multimodality therapy with or without lymphatic tape had improvement in external lymphedema measures using tape measurement, but there were greater improvements noted when tape was added. Quality of life parameters also shown to improve. So the use of medical tapes, although challenging in the head and neck region, has got some merit in terms of improving lymphatic drainage. Compression's a core modality that we use in all forms of lymphedema, and particularly in the head and neck. It certainly hasn't been examined yet as a single modality intervention, but has been as part of a comprehensive lymphedema program. We have, in the last few years, had access to a far wider range of head and neck lymphedema compression garments than perhaps we had in the past, and this is, I think, improved patients' ability to adhere to wearing regimes for compression. Some devices don't suit certain people and suit others. So now if you look in the bottom left, it's just a small example of some of the ranges of compression that we have. we try to start people using these devices intermittently, and we try to build up that wear time, knowing that the more hours that we wear compression, the more effective it will be. With the head and neck and the interruption to function, we tend to try to build overnight and then supplement with day wear as it might be tolerated. Pneumatic compression's a recent evolution in head and neck lymphedema compression, where it takes the sequential intermittent pneumatic compression devices used in limbs, and FlexiTouch in the US has produced a device that can be used in the head and neck region. It has been researched reasonably well so far in terms of having positive effect. It's been shown to be safe, contribute to symptom reduction, and even in external and internal lymphedema, there's been early signs of benefit. We haven't got an Australian device available in market yet, but I had a look at one last week, and that should be coming out in the near future, which will, I think, be a really useful adjunct for people who struggle to use the standard compression and also struggle with manual lymphatic drainage. Pneumatic compression, I think, does that in a more automatic way for them. Photobiomodulation is something that's used, previously described as low-level laser therapy, where we use laser or light-emitting diodes to cause physiological changes in tissues. In the head and neck, it is fantastic at reducing fibrosis and improving lymphatic flow. It's a pain-free, non-invasive treatment that is very well tolerated by people, and has got some reasonable efficacy data behind it as well. It's delivered over a course of treatments, and probably the most consistent research would show us that at least 6 sessions are needed for observation of some benefit. That probably leads into skin care and scar management, which we use as essential modalities in head and neck lymphedema treatment. Skin, ensuring intact skin and returning people to skin hygiene and maintaining their skin integrity after head and neck cancer treatment, in terms of reducing signs of risks of cellulitis. And scar work is really essential to try to improve that lymphatic flow. We've seen with the ICG imaging that the thicker the scar, the more difficult it is for the lymphatic fluid to traverse the scar. The more mobile, the easier that is. So we work on scar both to improve range of motion, but also improve lymphatic flow. And another emerging, I think, tool in the head and neck lymphedema world is the use of negative pressure therapy, where we use suction devices to achieve macro and micro strain, where they're aiming to affect cellular activity, but also aiming to open lymphatic capillaries and encourage lymph flow. Again, needing further research in the head and neck space, but this is a really positive, where I see clinically a really positive tool in terms of breaking down fibrosis, improving the tissue ready for manual lymphatic drainage or compression to be more effective. So I think a tool we'll see a lot more of in the future. Internal lymphedema management, I just wanted to touch on specifically, and if we think external lymphedema management is lacking in research, then internal is even further behind that. The only studies that have been done so far have been done quite recently and have looked at the use of really the use it or use it principle through radiotherapy, where that encouragement of maintaining swallow and swallow exercise for improved functional outcome is also thought to have a positive impact on internal lymphedema. What we don't know, I think, at this point is whether our external techniques can in fact improve internal head and neck lymphedema. And we try to be really upfront with people who present with more problematic internal than external lymphedema, that is an evolving space. And while some do find benefit, we don't have conclusive information about that yet. So I think support from a lymphedema therapist in that early instruction in conservative management, aiming to transition to self-management, is where we see our best head and neck lymphedema treatment outcomes. And early referral is probably the key to that, where we see daily head and neck lymphedema referred at the 6, 12 or even 18-month point. It involves a lot higher rates, a higher need for self-management and therapy-led management than if people are referred early on with early symptoms. So I'd leave encouraging you to consider identifying your local sources and how you can refer early to those. And just thank you for the opportunity, Sally, to present tonight.
Thank you, Amanda. That was a really comprehensive overview, and hopefully allow us to all become more aware of the symptoms and, really have an understanding about some of the, the starting approach on managing this very difficult problem. Thank you. So our next speaker will be Dr. Ying Sheng Lin. So Ying Sheng is, kindly wake up early and presenting from Boston. So, thank for the extra effort. So thank you for joining us today and sharing your experiences in, some of the surgical management, which is obviously still a very new area, but will be really interesting to hear his experience. Thank you.
Hi, good evening, everyone. Let me share my screen. Can you guys see my screen? Okay. Hi, good evening. I'm Ying Sheng Lin. I'm actually from Taiwan, and today I'm going to talk about the lymphovenous anastomosis for the treatment of the head and neck lymphedema. So head and neck lymphedema is actually quite common. So for up to 90% of the head and neck cancer survivor, they could have this kind of complication. So the primary causes could be the neck dissection and the radiation. And there are two types of the head and neck lymphedema, the external type and the internal type. So for external type, we can see the swelling. And for internal type, we cannot see the swelling, but people will have the difficulty in swallowing or some speech difficulty. To evaluate, I use the patient-reported outcome like the lymphedema symptom intensity distress survey, and also I use some clinician-reported outcome like the MD Anderson rating scale. So in terms of the treatment, just like the previous speak mentioned about, there is a complete deconstructive therapy, which include compression bandage, skin care, and manual lymphatic drainage. But there are always some barriers, like sometimes it's not covered by the insurance, and the patient they have to go to the clinic every week, and also the compliance. I think no one would like to wear like this and to walking on the street. So I start from 2021. I use the lymphovenous anastomosis to treat this kind of patient. So at first, I got the referral from my ENT colleague. The patient had the lymphedema more than 6 months. So initially, I will order the CT scan to evaluate if there is still cancer there or if there's a recurrence. And I will order a lymphocytography to confirm if it's a lymphedema, and also to make sure which side there's an impaired drainage. And then I will perform the LVA or LNVA if I cannot find the lymphatic channel. So LNVA is short for lymph node venous anastomosis. And I will use some specialized scale to follow up. So in terms of surgical technique, so we can do it under supine or lateral. So if the patient had wider shoulder, you can imagine it's kind of difficult to pull in the microscope if we put the patient under the lateral position. So if the patient's shoulder is wide, we have to put the patient in supine and turn the neck, because usually we will perform the LVA around the pre-auricular area. And I will inject the ICG over the temporal area, just like the photo here. I will inject here, and we can see the lymphatic drainage flowing down through the pre-auricular area. And also we will see some lymphatic channel around the mandibular area. And I will make a incision about 3 to 4 centimeter. And we can do either end-to-end or end-to-side anastomosis. So this is my first case. This is a typical case, 63-year-old male. He had right partial glossotomy and lymph node dissection, and he had right facial edema for 6 months. So this is the intra-op photo. I made a pre-auricular incision, and I found a lymphatic channel at the subsmart plane. Under microscope, so this is the lymphatic channel, this is the vein. So we can confirm the patency by the ICG. And this is pre-op, post-op 1 month. So actually the swelling did not subside significantly, but at his right cheek, we can feel it became much softer. The scar was hidden well. This is post-op 1 week, post-op 1 month. And in this case, I performed LVA through the submandibular area. So I performed the end-to-side anastomosis. So I hook up with the end of the lymphatic channel to the side of the vein. This is the immediate post-op. And sometimes we cannot find the lymphatic channel, but we almost always can find lymph node. So we can do the lymph node minus anastomosis. So this is the lymph node, and we can poke a hole over the lymph node and just hook up with the vein. So, and we also can confirm the patency by the ICG. So from 2021 to 2024, I did a LVA for 6 patients with the head and neck lymphedema, and the average follow-up is 15 months. And to evaluate for the external type, I use the MD Anderson scale, and for internal type, because all my patients with the internal type, they have the swallowing problem. So I use the swallowing quality of life questionnaire to evaluate. And for either external or internal type of patient, I use the lymphedema symptom scale to evaluate for the follow-up. So on average, the follow-up is 15 months. So the lymphedema head and neck score reduced from 1.1 to 0.4. It's a statistically significance. And for external type, on the follow-up of 15 months, the MD Anderson rating scale improved from level 2 to level 0 or level 1A. It's also statistical significance. And for internal type, for the follow-up of 21 months, the swallowing questionnaire improved from 130 to 151, but it's not statistically significant. So the advantage of the LVA, so we know the wound is very small, and which is very important in the face, because in the leg or arm, patient might not care so much about the scar, but in the face, they do care. Yeah. And then the quick recovery. So LVA can also be performed under the local anesthesia. And based on my preliminary study, it works for both type, either internal or either external or the internal type. And because we have been using the LVA to treat extremity lymphedema for several years, so it's kind of a proven technique. And I have published my preliminary result on the PR score. So if you guys want to know more detail, you can go check this paper. And I think in the future we need more patient with a comparison group and with a longer follow-up. And also right now, more and more people are doing the so-called immediate lymphatic reconstruction for the breast cancer patient who receive axillary lymph node dissection and to prevent the arm lymphedema. So if the head and neck lymphedema is also a problem, we might consider to also perform the immediate lymphatic reconstruction during the head and neck dissection. And also people are talking about we can use LVA to treat some neurodegenerative disease such as dementia. So maybe in the future we can also to see if we perform LVA on this kind of patient, will there anything change in terms of the dementia? So that's it. Any questions or comments?
Thank you, Ying Sheng. I think obviously, surgical side of things are always pretty exciting, but it's still very early sort of days for a lot of the surgical treatment, but look forward to you publishing more data on this. Thank you.
Okay, thank you.
There is a question for you, because I know you might have to go, but I might quickly ask you before I hand over to Tian. Someone was asking, what is the best time to do the LVA or LNVA? Is there a time that it doesn't work? It might be, a very big question.
Yeah, and it's a good question. So I remember for the first 1 or 2 patients, I got a referral when patients have the persistent lymphedema for more than 6 months, because I know for a lot of patients with head and neck lymphedema, they will just disappear within maybe 2 or 3 months. So at first, I only treat those patients with the lymphedema more than 6 months. But then I remember after the first 3 cases, they work well. So my ENT colleagues, they start to refer the patient who just have the lymphedema maybe for 1 month, because they feel very uncomfortable. And the LVA is a very minimally just a small wound, and we can do it under local anesthesia. So I start to treat the patient, maybe they just have the lymphedema for 1 month, and they will feel the improvement within days after the operation. So in my opinion, because I think the LVA will not cause any harm, and the wound is so small. So if we can provide some benefit for the patient, and right now if the patient wants this kind of operation, I will just provide. Yeah, so I will not wait. Yeah.
All right. Well, thank you. Thanks for
Yeah.
the perspective. All right. Well, finally, we've sort of come to Tian's talk. So, Tian, are you happy to share your slide? Just talking about your just to sort of lead back onto a little bit of the clinical sort of imaging that Amanda sort of brought about before, and you can show us what we can see on CT scan about lymphedema.
Yeah, sure. So thanks, Sally, for inviting me to speak tonight. I'll just share my screen. So my name's Tian. I'm one of the radiology registrars at Austin Health in Victoria, and today I'll be doing a talk on the CT assessment of head and neck lymphedema. I'm currently completing a retrospective review of CT changes in patients who underwent radiotherapy as well as surgery for head and neck cancer, with the aim of determining the prevalence of CT changes in this population. So as an overview of the role of CT in the assessment of head and neck lymphedema, CT is currently widely used as baseline for staging, as well as to assess treatment response in head and neck cancer. As well as being widely available, it is also non-invasive compared to other assessment methods for head and neck lymphedema, specifically for the assessment of internal head and neck lymphedema, which is usually done with internal laryngoscopy. In addition to this, unlike other assessment tools, CT allows us to assess for both external and internal head and neck lymphedema simultaneously. Despite the benefits of CT, it's currently not routinely used to assess head and neck lymphedema, and there's multiple reasons that contribute to this. Firstly, there are very few studies on the use of CT in the assessment of head and neck lymphedema. And secondly, there's a lack of wider awareness of the appearance of head and neck lymphedema on CT. So the previous studies or existing studies on head and neck lymphedema on CT have been limited to descriptive processes only, until more recently in 2018, when Olino developed this assessment tool that addresses the previous lack of standardized methods for the assessment of head and neck lymphedema. And this is the tool that I've been using for my project. It's a grading tool for assessment of head and neck lymphedema at specific anatomical landmarks on CT neck, which can be consistently applied across multiple CT studies. It also includes assessment methods for internal head and neck lymphedema, which previous studies in the literature lacked. So the tool that they've developed is called the CT Lymphedema and Fibrosis Assessment Tool, or CT LIFAT for short. And the criteria proposed are as follows. So for assessment of external head and neck lymphedema, the tool uses the grading of fat stranding at 6 locations on CT neck. On an axial CT neck at the level of the superior thyroid cartilage, the tool assesses fat stranding at the bilateral anterior and posterior cervical spaces, as well as the midline anterior neck subcutaneous fat. On the midline sagittal CT neck, it also includes assessment of fat stranding in the submental space. For internal head and neck lymphedema, the tool grades epiglottic thickness, as well as prevertebral soft tissue thickness at the level of the C3 vertebral body on a sagittal midline CT neck. So some examples from our participants. This is an example of mild changes in a patient who had SCC of unknown primary origin and underwent radiotherapy to their bilateral cervical lymph nodes. Comparing their CT at 3 months post-completion of treatment compared to their baseline, we can see mild fat stranding in the bilateral anterior cervical spaces, as well as in the anterior subcutaneous neck tissue. The posterior cervical spaces are relatively well preserved compared to the baseline. On the sagittal CT neck for the same patient, we can see on the 3 months post-treatment CT that there's mild fat stranding in the submental space. And when assessing for internal head and neck lymphedema, looking at epiglottic thickness as well as prevertebral soft tissue thickness, we can see that there's been a significant increase compared to the baseline study. This is an example of severe changes in a 44-year-old man who had tongue SCC and underwent a hemiglossectomy, bilateral lymph node dissection, as well as post-operative radiotherapy. And we can see severe fat stranding in the bilateral anterior and posterior cervical spaces, as well as the midline anterior neck subcutaneous fat. For the same patient on their sagittal reconstructed images, we can see severe fat stranding in the submental space, as well as thickening of the epiglottis and prevertebral soft tissues compared to their previous study. So this is a summary of our preliminary findings in 168 patients who were treated for various cancers of the head and neck. We've divided our participant group into those who underwent radiotherapy alone for treatment, into those who had radiotherapy and surgery without a neck dissection, and finally those who had radiotherapy as well as surgery with a lymph node dissection. We can see at the 3 months mark that all patients in the study had at least mild changes on CT, with very few patients having normal CT at that time period. There were similar findings in those who underwent radiotherapy alone and those who had surgery with post-operative radiotherapy, with the majority of the patients having mild changes at 3 months, with a significant proportion having ongoing mild changes at the 6 months study. In those who had radiotherapy and lymph node dissection, the 3-month post-CT demonstrated the majority of patients had advanced changes, with ongoing advanced changes at 6 months post completion of treatment. So comparing these 3 groups, we saw a significantly higher proportion of participants who had a neck dissection have more significant changes of fat stranding in their neck on CT. For internal head and neck lymphedema, we measured both the mean epiglottic thickness and prevertebral soft tissue thickness at several time points post treatment of head and neck cancer. And we can see a significant increase in both epiglottic thickness and prevertebral soft tissue thickness at 3 months for all groups. At 6 months, we see a slight decrease in thickness for all participants. However, we can see that these changes don't decrease back to the baseline levels. And there were similar findings amongst all groups. So in summary, while CT has great potential for use in assessment of head and neck lymphedema, there are some limitations. And the main limitation is that the CT findings need additional validation by correlating findings to patient-reported outcomes or clinical assessment tools in order to establish validity. The treatment implications for these CT findings are also unclear, but I believe it's important to first develop an assessment tool on CT that we can reliably use in order to address this otherwise under-recognized clinical issue. And finally, I think it's important for radiologists as well as other readers of CT to be aware of the potential changes, post-treatment changes on CT neck, which may have significant functional impact on head and neck lymphedema patients. So that's the conclusion of my talk. So thank you.
Thank you, Tian. I think certainly, we always order CT as part of the head and neck cancer follow-up, but I think we don't necessarily have the awareness of how that implication, may lead to the symptoms. So it'll be interesting to obviously look further into, how that sort of correlate with the clinical symptoms that patient reported. So thank you for sharing that. So I think now we're going to come to the Q&A. Just before we do that, I do want to remind everyone that we have a survey. If you can, kindly do a quick QR code scan and then let us know your feedback tonight, that would be great. And I also just want to, thank Hedman again for sponsoring tonight. I might pass the Q&A session to Eric. I know he's been probably keeping an eye on all the questions for us. Thank you, Eric. Yeah.
Thank you, Sally. Yeah, with the remaining 5 minutes, we got a few great questions here. I think this question is addressed to Amanda. The question is, who can prescribe this treatment modality that you mentioned in your talk? Do we need special training or courses? And where can patient access this care?
It is considered a specialist skill, but the Australasian Lymphology Association is the peak professional body for lymphedema in Australia. Lymphoedema.org.au is their website. They have a list of registered training providers on there, and they also have a list of registered practitioners. Practitioners for head and neck lymphedema now include occupational therapists, physiotherapists, and speech therapists, and they can all do a postgraduate training course in head and neck lymphedema that allows them to provide these treatment modalities.
Great. The other question to follow on is, are there prophylactic activities we can give to our head and neck surgical patient to prevent lymphedema? For example, gentle head and neck, range of movement activities.
I wish I could say yes, but there's a lot of time and energy spent researching this in the post-breast cancer population, and we now have got some, whilst certainly not preventative, we know very clearly that close monitoring and early intervention in the post-breast cancer population leads to reduced rates of lymphedema in the long term and milder lymphedema in those in which it does develop. We do not have that data in head and neck lymphedema, so I can't clearly say if there's a particular program of activity that you could do in terms of prevention. I think it would be considered good clinical practice, though, to look early on at skincare, certainly early gentle scar management techniques and early range of motion, because we know if that skin scar and neck and shoulder range of motion are restricted or impaired, that's going to lead to further complications with lymphedema in the long term. And I think if they're done in a gradual way, with close monitoring, those things can be started early and can be helpful in the long term.
Thank you. Robin is interested to know, have you used deep oxalating therapy in the management of lymphedema and scar therapy?
So I didn't cover deep oscillation therapy. It is something that has been used in a few case reports in lymphedema. Even in peripheral limb lymphedema, it's woefully lacks any sort of strong data behind its use, and therefore it's considered in limb lymphedema an alternative therapy. And I think that would be even less strong a recommendation in head and neck lymphedema. It just doesn't have, I say there's weak data behind other modalities. I don't think there's any data behind that in the head and neck region. And we really like to be careful with the introduction of new modalities to the head and neck because of the associated structures and the need for, evaluation of, carotid safety, etc., before we progress. So it's not something that's used frequently. It may be something that becomes useful in the future, but not something that's widely practiced in the head and neck at the moment.
Thank you. I think last question. I think this question is addressed to Ying. When you talk about swallowing problem, are you referring to laryngeal swelling leading to impaired airway protection or pharyngeal dysmotility? How are the swallowing problem being diagnosed? Is it through video fluoroscopy or FEES? Not sure whether Ying is online, but perhaps I can open this to the panelists.
Might be a question for Amanda, I think.
Okay.
I'm not sure I'm a swallowing expert. I wouldn't want to misrepresent my speech therapy colleagues here, other than to say I think both those things occur. I think in the previous talk, the reference was to patient-reported outcomes, so I doubt they would delineate between pharyngeal and laryngeal issues. And I think one of the things that we know is that swallowing difficulties and all of the functional implications of head and neck lymphedema are very common after head and neck cancer treatment. But clearly there are greater numbers of those side effects in people who also have lymphedema, and they are also reported to be more severe in people who have undergone head and neck cancer treatment and then get lymphedema. So greater rates of swallowing difficulties of both formats in our centre. I think both of those imaging techniques are used by my speech therapy colleagues to assess for swallow and sometimes even repeat assessment to identify progress or deterioration as conditions progress.
Yeah, I certainly think a lot of the times is probably a combination of the two techniques that you sort of need to do to look at that. But I guess that's really depending on the speech pathology sort of department assessment, isn't it? I think, yeah. I guess I do have a question, like the sort of a couple of things floating in, but I think Ying Sheng's not here, but I'm sure.
Hi, this is Ying Sheng.
Oh,
I
yeah.
can
Okay. All right.
Sorry about that. So
No,
yeah, so my patient with the swallowing problem, my ENT colleague, he used the scope to evaluate. He saw the swelling of the patient's vocal cord. So that's why he felt on the patient might have some lymphedema problem. And we performed the lymphocytography. We inject the TC99 over between the eyebrow, and we found there's one side of the face there was a impaired lymphatic drainage. So that's why we can diagnose or the patient has one side of the lymphedema problem, and that's how we can decide where we are going to do the LVA.
Yeah, thank you.
Yeah.
I think I do have a question for Hiroo. Just sort of obviously the ICG is displaying the the superficial lymphatic beautifully, and I think that sort of help us to understand a little bit about the obstruction point, perhaps like where surgery and radiotherapy may be leading to, and certainly may help to facilitate procedures like LVAs and all that. But what's your thought about the deep sort of system, and obviously when you're talking about taking sort of deeper node and what I guess with your understanding of the dissections and different imaging modalities, perhaps like how do you think we can have a better understanding about the impact on the deeper?
Yeah, so I prefer using the indocyanine green because the imaging can be performed at the outpatient clinic setting. So, however, indocyanine green having a big limitation for the penetration. So doesn't having the ability to catch the deep information. So that's why the probably need a additional imaging modality. It's might be the SPECT-CT, but SPECT-CT is probably too much right now. So that's a part is still in like a future homework right now.
So at this stage, we're probably very much limited to that sort of external or superficial lymphatic space at this stage anyway, looking at that.
Yeah, that's unfortunately, that's I think the current condition.
No, that's great. All right, well, I think I don't think there's any other major. Oh, well, Ing actually had a question, just final one. Why is surgical lymphatic mapping not more widely available or known in Australia? Anyone want to tackle that question? Resource limited. Hiroo, do you have any feedback on that?
So I think the main point may be the patient attention to the lymphatics. If the patient having a more like a sort of the lymphatics, and then so the people consider this is an area of the need, and then this kind of the like a curiosity and the interest probably to push forward to so facilitating the application of the lymphatic imaging. So unfortunately, the Medicare is not covering right now. So, but once the people are, so I personally say that that's a great tool because the patient also can watch to see what's happened on the monitor. So it's like a head and neck lesion. It's quite difficult to diagnose, and then surgical deformity, and also the like a sensory nerve damage. So hardly for evaluated. The swelling comes from the leaf tissue swelling or some of the tissue changes after the surgery. So then hopefully the patient pay attention more about the lymphatics. This kind of the motivation can push forward to the more easy to the access for the patient to the lymphatic imaging.
Yeah, it's a tricky one. I think it's obviously very much driven by resource availability. You've got to have that specific machine available to be able to do that. But I think this is just like as most of our head and neck cancer patients survive longer, we've got to think a little bit more about the functional outcome for this, and hopefully this really helped to raise the awareness of you know, the lymphatic burden that we had on the patient, and we can drive more of these services being available. I think, you know, we're at sort of 8:24, so I'm conscious of time, but I really want to thank everybody for attending tonight, especially to our panelists for you know, donating your precious sort of hour and a half tonight to share your wealth of knowledge. If you haven't had a chance to do your feedback, we hope that, you know, you can do that for us so we can continue to improve the quality of our webinar. And finally, thank you to everyone again for coming tonight. Thanks very much.
Thank you, Sally. Have a good night.
Oh, you know, thank you. Please feel free to go, just sort of stay and farewell, everyone. But thank you.
Thank you.
Thanks, everyone.
Bye.
Well done. Fantastic
Thanks,
talk.
Sally.
much.
Thanks, everyone.
Great attendance. Yeah,
See
well
you
done.
next time. Bye.
Evening.
Good
Thanks.
night.
Good. Okay. I'll stop recording, I think.
Oh, you have stopped recording? That's
Yeah,
right. Yeah.